All right. So today we're going to talk about psychological disorders. This is a two-part lecture series. So this will be the first part, and then there will be a second video that covers the second half of this lecture. So we're going to begin by spending a little bit of time defining abnormality, talking about what is well-being, what is disorder. Then we'll spend some time talking about who decides. We'll go through and we'll talk about the Diagnostic and Statistical Manual. We'll talk about specific disorders. And for this first half of the lecture, we'll talk about anxiety. And then when we come back for the second half, we will cover dissociative mood and schizophrenia, dissociative disorders, mood disorders, and schizophrenia. So when we talk about abnormal psychology, when we talk about psychological disorder, we really need to begin with the question of what is normal. Is normal simply the absence of disorder? Am I considered normal because I simply have not been diagnosed with a particular psychological disorder? This thinking about normality raises kind of this question, is what is normal purely subjective? So for example, Lady Gaga, pop singer, wears a meat dress to the Video Music Awards, right? It's a dress that is made completely out of meat. Is that normal, right? Or is that disorder? If you ask my grandma or your grandma might say, well, there's something wrong with that girl, right? That's clearly something is wrong. Clearly that's not normal. Right, but the question still remains. Is this subjective? Right? Lady Gaga might say, "Well, I'm calling attention to, mistreatment of animals in our food production system, and so to her, this might be a completely rational way to do this." But again, it raises this point that what is normal, and how do we define what is normal? And there's a few different ways that we define normality, or as we like to talk about it, psychological well-being. So we talk about psychological well-being as sort of general contentment with your life, with elements of your life, being sort of a relative peace, relative happiness. Again, sort of generally satisfied with aspects of your life. Right, to call this psychological well-being. We talked about this last time as sort of subjective well-being. And there are sort of 6 dimensions that some researchers have identified as being dimensions of well-being. So the first one is self-acceptance. The idea of self-acceptance is that people who are high in self-acceptance have a positive attitude about themselves. They are generally positive attitude, but they also accept both the negative and positive qualities. So they are aware of their positive and negative qualities, and they accept these. People who tend to be psychologically well tend to have positive relationships with other people, right? So they're satisfying relationships, they're healthy, they're warm, they're trusting, they're concerned about the welfare of other people, they're capable of showing empathy and affection, and intimacy, understand sort of the give and take nature of human relationships. People who are psychologically healthy tend to have a sense of autonomy. They feel self-determining and independent. They're able to resist social pressures, regulate behavior from within. So they're able to exert self-control, resist social pressure, and they evaluate themselves in terms of their own personal standards, not necessarily the standards of others. Psychological well-being is in part about feeling a sense of mastery. So the idea of mastery is that you feel like you are competent in managing your environment. You feel like you are in control of the activities that you do. You feel like you make effective use out of the opportunities that you're given. You feel like you can create context, you can create situations that are suitable for your personal needs and values, right? So you feel an overarching sort of sense of control in your life. You feel like your life has purpose. So you feel like you have a sense of direction, that there's meaning, that you have sort of objectives and aims, or sort of goals and reasons for living. There are things that you are trying to do and accomplish. And you feel like you can grow. You feel like you're continuing to develop. You see yourself as open, as expanding. You're open to new experiences. You see improvement in yourself over time, right? So you feel like you are better off now than you were 5 years ago in terms of personal growth, in terms of your social and your employment kind of growth. You feel like you're changing in ways that reflect, increased self-awareness, increased self-knowledge, towards positive experiences. So these are the 6 dimensions of well-being. It's important to note that in order to be considered psychologically well, you don't have to be super high on all of these. You don't have to score, for example, if we were taking some kind of exam, some kind of test. You don't have to score super high on all of these characteristics to be considered psychologically well. It's sort of a matter of degree and frequency, right? Some days we have good days, some days we have bad days. Some days you feel, sort of aimless and you feel like you're not really sure what you're doing with your life. And some days you sort of feel like you've got things under control. But psychological well-being is about this degree and frequency. It's mostly positive most of the time. Psychological disorder, on the other hand, generally speaking, is a psychological state or condition behavior that causes you to suffer. It's self-destructive. It impairs your ability to get along with others, or it endangers others. It impairs your ability to function socially, to hold a job, to do the things that you need to do in your life. One of the common themes of psychological disorders is this idea of suffering and impairment. But it's also a matter of degree and frequency. So psychological disorder is characterized by mostly negative affect most of the time, right? So we can talk about disorder, dimensions of disorder. Now, these don't necessarily map one-to-one onto the dimensions of well-being, but they sort of characterize aspects, common aspects of psychological disorder. So the first is suffering. Suffering is unpleasantness, pain. It is psychological or physical anguish, right? It is you are in a state of suffering, right? So one of the things that it characterizes disorder is suffering. Deviancy also characterizes disorder. So one of the things that we'll talk about later on when we talk about specific disorders is that in many cases, psychological disorders are normal behaviors or usual behaviors that are sort of turned to the extreme, or they become rare behaviors or unusual behaviors. Now, again, we're not talking about deviancy as in sort of bad, we're just talking about rare and unusual. So if you think of sort of the distribution of mood, for example, right? Most people are around the middle of this distribution, right? They're, kind of happy or kind of sad. Sometimes you have really positive things and you're really happy. Sometimes you have really negative things and you're really sad. But when we talk about deviancy in terms of psychological disorder, we're talking about, being really, really sad for years at a time, or months at a time, or weeks at a time, like really extreme or unusual behavior. That's when we start to get into this, into the realm of disorder. Other dimensions of disorder are maladaptiveness. So these are behaviors that interfere with your life. They prevent you from doing the things that you need to do. These can be sort of self-destructive. Going out and spending all, charging up all of your credit cards in a sort of manic state, or you can imagine someone who's so depressed they literally just can't bring themselves to go to work, and so they lose their job, right? These are sort of maladaptive behaviors. They can also prevent us from enjoying social relationships, these sorts of things. So disorder is characterized by maladaptiveness, thoughts or behavior. Also norm violation, right? So failing to follow social rules, failing to follow conventional standards, things that For example, there's a social norm that people wear clothes, right? If you walked into a classroom and a student next to you just started taking off all of your clothes, this would be a norm violation. This might also result in social discomfort, right? So violating society's conventional standards, but also, behavior that is that causes discomfort in other people, right? So someone taking off all of their clothes in your class would probably cause you some amount of discomfort. Here's another fun one that's also a violation and causes discomfort. If you ever get into an elevator and it's a really packed elevator, just get in and stand there and don't turn around and face the door. Just look at all of the people in the elevator, right? That will make them all very uncomfortable, right? And this is sort of an example of this idea of social discomfort. Most people, when they get into an elevator, they turn around. Most people wear clothes all of the time, right? Social norms, social discomfort. Also, disorders characterized by irrational or unpredictable thoughts or behavior. We like people to behave a particular way. We like to have an orderly and predictable environment. And we like people to be predictable. People who are unpredictable, unpredictability is characterized is one aspect of psychological disorder. So you can imagine, being in the elevator, right? The way that people use the elevator, they get in, they push their floor, they get out, right? If someone gets into the elevator and they immediately start jumping up and down violently, like that's kind of irrational, unpredictable behavior, right? And not necessarily a disorder, but it's sort of characteristic of psychological disorder. Okay. So these are the dimensions of disorder. The next thing that we need, so we've sort of talked about this idea of what is psychological well-being versus what is disorder, what characterizes disorder broadly. But it still doesn't resolve this sort of question of the inherently subjective nature of psychological disorder. And so it raises this sort of question of, well, who decides, right? If many aspects of psychological disorder are socially prescribed, right, they're based on social conventions and rules, then who decides? And the answer is the American Psychiatric Association. American Psychiatric Association, made up of psychiatrists. If you're not familiar, if I haven't mentioned this yet in my web lectures, those psychiatrists are medical doctors, whereas psychologists have PhDs primarily. And psychiatrists, their primary role is to prescribe medication and look at the psychopharmacological side of disorder. They're also involved in doing research on psychological disorders. Psychologists primarily involved in doing therapy and conducting therapy. They also do research on disorders as well, but the one thing that they can't do is prescribe medicine. Okay, so that's the distinction between a psychiatrist and a psychologist. The American Psychiatric Association periodically publishes what we call the Diagnostic Statistical Manual of Mental Disorders, the DSM. Right now we are on the DSM-4 TR. TR just stands for text revision, 4 just stands for the fourth version. The DSM is the accepted standard for defining mental disorder. It tends to be primarily descriptive in nature, and it covers things like the symptoms of a given disorder, the age of onset, predisposing factors, course of the disorder, right, how long it lasts, what the symptoms of the disorder are, and these sorts of things. The DSM, the purpose of the DSM is to provide this sort of classification system, right? The idea behind the DSM is, okay, let's put into words, put into one book, the list of symptoms that we have decided as psychiatrists count as depression. What does depression look like? What does it mean for you to be depressed, right? We have this sort of very explicitly spelled out definitions and symptoms for depression in the DSM. And the idea is that mental health professionals around the globe can look at this one document, this one book, and can reliably treat and identify and treat specific disorders. right? So the idea behind the DSM is that a person with a collection of symptoms could go into any psychologist or psychiatrist's office, and the psychologist or psychiatrist could look at those symptoms, look at information about the individual, compare that to this DSM, and come up with a diagnosis. Right? It also establishes the range of problems that health professionals can address, right? So the DSM on some level defines what is and what isn't psychological disorder. And it also specifies which potential treatment approaches are useful for which potential or for which kinds of disorders. And we'll talk more about that next week when we talk about therapy. So the DSM does this classification very well. The DSM does a really good job sort of classifying identifying symptoms of disorder, classifying what is necessary in order for someone to be considered to have a psychological disorder. And this is really useful. It's a really good thing about the DSM. I start by saying this is a really good thing in order to put in sort of this is really good, but, right? So there are pros and cons to the DSM. One of the pros, the big pro, is this sort of classification system, right? It allows for reliable diagnosis, right? It's a standard by which all health professionals can evaluate particular clusters of symptoms to help people with psychological disorders. But there are problems with with classification. One of them is this idea of social stigma. People who are diagnosed with psychological disorders may be seen by other people as being inferior or deficient in some way, and this can lead to stereotypes and prejudice. Right? You might have it in your idea of what you might have an idea in your head about what depression looks like and what depression means. And if someone says, "Well, this person is depressed," then you have all these sort of preconceived notions about what that person is like. Right? And this is potentially problematic, especially if there is a stigma attached to having bipolar disorder, for example, or depression, something like this, or any kind of mental disorder. And these can include these things like labeling effects. So the way an individual views themselves might actually be influenced by the presence of this label of a psychological disorder. And it also influences the way that we view other people. So for example, take a look at this photo, and I would say, usually I would ask, a classroom of students, how do you interpret this picture? And, when you look at this photo, many students will say, well, that little boy is shoving his sister, that little girl is shoving her sister. Maybe they were both running into the room to play with a toy, right? There's a lot of different ways that you could interpret this picture. Now, what's interesting about those interpretations is they tend to be relatively benign, right? Well, they're just brother and sister, or their kids just playing, right? Maybe it was an accident. But then I tell students, well, what if I told you that this child in the green here has been diagnosed with oppositional defiant disorder? Now, you have no idea what, potentially, I assume, most students have no idea what oppositional defiant disorder means, right? Most students don't. But simply adding that label tends to change how students view this picture, right? All of a sudden, it implies that this little child in the green is acting intentionally towards this little girl, right? Oppositional defiant disorder just sounds bad, right? Maybe he's shoving her on purpose, right? Maybe he's, trying to hurt her, trying to knock her down, or trying to do these things. But again, the point here is that simply adding this label, oppositional defiant disorder, has completely changed the way that you see this picture. Perhaps not for you, but does sort of, generally speaking, when I do this in classrooms, changes the way that people see this, right? And this is problematic in terms of classification of mental disorder. Another problem for the DSM is this idea of this illusion of objectivity, right? So we mentioned at the beginning that psychological disorders are sort of inherently subjective, right? There are these characteristics and dimensions of disorder and well-being, but the question is, where do you draw the line? When do you draw the line? And this tends to be these subjective decisions. But having this sort of book that is codified by these psychiatrists makes it seem objective. But at the end of the day, what is psychological disorder is in part based on society's standards of what is socially acceptable, what is not. It can even be political or economic pressure that determines disorder. So a couple examples. PMDD, premenstrual dysphoric disorder. This is an official disorder in the DSM. It refers to PMS, premenstrual syndrome, right? Sort of fluctuations in mood that occur right around the onset of menstruation for women, right? Is this a psychological disorder? That's sort of up for debate. Now, there's some controversy surrounding the inclusion of this in the DSM, in part because there are major drug companies that make drugs that sort of help to treat PMDD, or that help to treat PMS. And as I pause, I'm doing air quotes and looking at the screen. But they treat these disorders, and one way to get insurance companies to pay for this is if it's an officially recognized psychological disorder, right? So there's political and sort of economic pressure to include this as a disorder. Now, is it truly a disorder? Well, it's kind of up for debate. I have here also another disorder. This was never included in the DSM, but it's a good example of this idea of cultural standards and social acceptability influencing what is and what is not psychological disorder, and this idea of drapetomania. Back in the Civil War era, pre-Civil War era, this was a mental illness that was characterized by slaves who had an urge to escape from slavery, right? Why would a slave want to not be a slave, right? If you don't want to be a slave, you must have a mental disorder, a mental illness, right? So again, based on society's sort of cultural standards at the time. The last one I have here is sexual orientation disturbance, right? Until the 1970s, homosexuality was considered to be a psychological disorder. And this was changed in the 1970s. So I have a link here to a radio program where they discuss the events surrounding this change, and I encourage you guys to listen to it if you have time. It's very interesting. It's very interesting to listen to, but it suggests this sort of there's a subjective and culturally based standard of what is and what is not disorder. So those are some of the pros and cons of the DSM, talking about sort of who decides what is and what is not psychological disorder. Excuse me. The next thing we'll talk about are different categories of disorder. So these could be psychotic, substance abuse, mood, anxiety, somatoform, dissociative personality, and sexual and gender identity disorders. These are sort of the major categories of disorders that you find within the DSM, and then there are all sorts of subcategories and diagnoses and disorders that are listed under these major headings. For the purposes of this class, we are going to cover anxiety disorders, dissociative disorders, personality disorders, mood disorders, and psychotic disorders. So next we'll talk about anxiety. We'll end there and we'll pick back up and talk about dissociative in the next installment of the lecture. So anxiety disorders, anxiety is characterized by this sort of feeling of apprehension or dread. It's kind of like an extreme fear response in the absence of a fear-provoking stimuli. So if you imagine yourself kind of walking down the street late at night and someone jumps out at you and points a gun at you, you're going to have an intense physiological reaction of fear, potentially, unless you're, some, MMA fighter and you've got them in a chokehold immediately or something like that. Right? Most people are going to have this intense fear response. Now, imagine feeling an overarching sense of dread or uneasiness, sort of overarching fear, but not in response to anything, just kind of periodically or all the time, right? This is this feeling of anxiety, right? Constant worry, constant tension, even though there's sort of little or no cause. Right? There's really nothing that sort of stands out as a source for this anxiety. A lot of times people will worry about multiple things, and they'll just kind of float from one thing to the other, right? So this person with anxiety is like, oh, I'm having such a tough time at work, and I just don't know what I'm going to do. I have all these projects to do, and I just can't get them all done. And my house is a mess, and I never have any time to clean it. And I don't know what we're going to do about our finances because we've got lots of credit card debt. And I've got this weird bump, and I don't know what's going on with it. It's in my shoulder, and maybe it's cancer, right? A person with anxiety, it's just sort of this chronic worry, right? And maybe it's chronic, it's overblown fears, right? And a person may even be aware that they're being unreasonable or irrational, but they're not able to do anything about this. Okay. Now, people have anxiety, right? So I have anxiety, you have anxiety, students have anxiety. You have anxiety about a test that's coming up. You have an anxiety about, maybe someone's coming to visit and you need to clean your house, right? We have anxiety about things. But the question is, when does it become a disorder? And it becomes a disorder when it becomes persistent, when it's disruptive, when it causes suffering or maladaptive behavior, right? You're so anxious that you can't leave the house, right? You're so anxious that you can't concentrate at work. You don't get your job done because you literally can't stop worrying about things. This is when we start to wander into the land of disorder. Okay. Now, when we talk about psychological disorder, we can talk about generalized anxiety disorder, which is, so this is anxiety. We talked about anxiety broadly. Now we're going to talk about specific disorders. So generalized anxiety disorder is a chronic state of tension or worry, must be persistent for at least 6 months. One of the other criteria for anxiety disorders is that there can't be sort of direct cause, right? So if you're worried about an exam, or you're worried about whether or not you're going to get a job, right? This is reasonable anxiety. But for generalized anxiety, there's no real sort of specific cause. You find it difficult to control the worry, and you feel sort of easily fatigued, irritable, difficulty concentrating. These are the symptoms of anxiety. Now, one can have sort of general anxiety, and you can also have anxiety with panic disorder. So panic disorder is general anxiety coupled with unexpected, severe, intense attacks of anxiety. So a panic attack, that's sort of like this intense feeling of dread and terror. So we call this a panic attack. Now, panic attack people with panic attack, it's almost like you're just kind of standing in line at the grocery store and suddenly you feel like you're gonna die. Like your entire body, you feel like you're just about to die. Intense dread, intense sense of terror. You become sweaty, shortness of breath. You maybe feel like you're choking or you have chest pain. You feel dizzy, lightheaded. You feel like maybe you're losing control, like you're about to just completely go crazy. You feel like you might be about to die. You're going to have a heart attack, right? This sort of intense, sort of out of nowhere, I'm about to die feeling. Panic attack. So people with general anxiety, chronic anxiety can have these panic attacks, and we would call this general anxiety disorder or we'd call this panic disorder. So general anxiety with panic attacks. But you could also just have general anxiety. You can also just have panic disorder. So you can be fine most of the time, and then out of the blue you have these panic attacks. Usually panic attacks last a short period of time, but they tend to be really, really intense and unpleasant. And they can develop into agoraphobia. So a person with panic attacks may have an overarching fear that these panic attacks are going to occur in public or unfamiliar places. And this leads them to worry about having these panic attacks in public. Right, and so they have anxiety about being in these public places, and they seek to avoid public places. So maybe they don't go to the grocery store, they don't go to work, or they don't go to school, these sorts of things. Now, that's anxiety, that's panic attack, and agoraphobia. You can also have sort of generalized phobias. So these are phobias directed at specific objects or situations. We've already kind of touched on this a little bit in this class. The trick to phobias is that they're irrational and excessive, right? So you can have a sort of a fear of dogs or a fear of snakes. And that can be kind of rational, right? A dog might attack you, or a snake might bite you. A snake could be poisonous. That's rational. But it becomes irrational when that fear becomes sort of intense or debilitating. Right? So, for example, agoraphobia, we talked about having agoraphobia with panic attacks. You can have agoraphobia just generally without panic attacks. So you can just have sort of a general fear of being embarrassed in public places, a sense of just uneasiness or just fear of being in public. You don't like crowds of people. And that becomes disorder when it interrupts your life and causes suffering, when it prevents you from doing the things that you need to do. So you're so afraid of being embarrassed in a public place that you don't go to work anymore. Or you can't go shopping unless you go at 4 in the morning when you know that there aren't going to be a lot of people there, right? Grocery shopping at the Dominick's or Jewel or something like that. There are a whole lot of other phobias. We can sort of classify these. These can be things like animal phobias, fear of heights, fear of bodily fluids, injections, injury, particular situations, so claustrophobia and fear of enclosed spaces, fear of air travel, these sorts of things. There's a whole list here. I've got a link here if you're sort of interested. You can check it out. There's a million different kinds of phobias. You can pretty much be afraid of anything, and they're all sort of listed out there. We'll talk next week about how to treat phobias, and we'll talk at the end here about where phobias come from. The next anxiety disorder we'll talk about is post-traumatic stress disorder. So post-traumatic stress is a psychological disturbance that lasts at least 1 month following some kind of traumatic experience. So people with post-traumatic stress usually experience some kind of major trauma and then start to experience symptoms of post-traumatic stress within almost potentially immediately or up to 3 to 6 months after the event. And these symptoms are things like haunting memories. These symptoms are things like nightmares. And these symptoms sorry, I'm just trying to find my notes here. And so these symptoms for post-traumatic stress disorder can lead to things like social withdrawal. They can lead to things like anxiety and insomnia. The person with post-traumatic stress sort of re-experiences this traumatic event over and over again, either through sort of intrusive memories. They just can't not remember it. Just kind of intrudes when they're not even trying to think about it. This event, this traumatic event comes into their mind. Intense psychological distress. When you see cues that are associated with this traumatic event. You avoid stimuli that remind you of this. You feel sort of emotionally numb, and these sorts of things. It tends to be the more frequent and intense the stressor, the more adverse and longer lasting the effects. Typically, we talk about PTSD among combat veterans, right? So soldiers who are experienced to some of the horrors of war and wartime scenarios. But this can also be for people who are disaster survivors. People who suffer sexual assault can also experience PTSD. So, for example, recently, there have been major events like 9/11, events like the Boston bombing that can really horrific traumatic events that can lead people to have these sort of symptoms of PTSD, haunting memories, nightmares, intense psychological and physical distress. One of the correlates of post-traumatic stress is that it may lead to the development of depression or anxiety disorders or substance abuse. You can get what we call comorbidity, where you start out with post-traumatic stress, but then you develop alcohol abuse as a way of sort of self-medicating to manage the stress of the anxiety. It could also be, full-blown depression, which we'll talk about a little bit later on. We can talk about obsessive compulsive disorder. So obsessive compulsive disorder has these two sort of parts to it. There are these sort of recurring irrational or disturbing thoughts that sort of intrude into consciousness against a person's will. So a person with a person with obsessive compulsive, they similar to post-traumatic stress in that they can't stop thinking about this irrational or disturbing thought. Right? They have these repeated thoughts, feelings, or ideas, and these repeated thoughts, feelings, or ideas drive them to engage in compulsive behaviors. Right? So there are these behaviors that help to reduce the anxiety that's associated with this irrational thought. Right, so you can imagine, so one of the common forms of obsessive compulsive are people who obsessively clean, right? So oftentimes this manifests in terms of hand washing. So a person might be really concerned about, germs in their environment, right? And so maybe they're on the L and they accidentally touch, something on the L with their hand. So they go and they start washing their hands. And they're really just worried, oh my God, I've got germs, right? And it's really intense and they can't stop thinking about it until they wash their hands. And then they wash their hands and it makes them feel better, right? But they have to wash their hands in a really particular kind of way. So first I've got to get a paper towel, and then I've got to turn on the water just like this, and then I've got to turn on the other water just like this, and then I've got to count to 125 2 times while I wash my hands. And it becomes this sort of very, very specific sequence of behaviors. These compulsions become very specific and sequential in order to alleviate the anxiety of the obsession. Right? So we talk about this as sort of a two-stage conditioning, right? So you have this intense anxiety about something, about germs or what have you. You discover that a particular behavior, a particular series of behaviors helps to reduce that anxiety, and then it becomes this sort of cycle. So I have the intrusive anxiety-producing thoughts, I engage in the behavior, they get tamped down for a little bit, and then they come back and I have to engage in these behaviors again. So a couple examples of anxiety disorder, of obsessive compulsive disorder. So the author David Sedaris is had an obsessive compulsive disorder when he was a child. And this link here is pretty interesting to listen to, and I strongly encourage that you listen to it. This will take you to, I believe, this should take you to a link that has, him reading from one of his books where he describes his obsessive compulsive behavior. And you only need to listen to about the first 4 minutes of it, but it gives you a really good sort of visceral experience of what it's like to be a person with obsessive compulsive disorder. I have here also listed hoarders. So I don't know if you're familiar with the show Hoarders, but this is another manifestation of obsessive compulsive disorder. People who hoard are people who literally just can't throw anything away. They have this sort of irrational thought that they're going to need something, right? Throwing things away causes them this severe anxiety, so they compulsively hold on to everything. Right now, you imagine that if you don't throw things away, you hold on to them, that over time this becomes really problematic and disruptive to where your house is just sort of full of junk. So again, another example of obsessive compulsive. So we can talk about the causes of anxiety disorders. So Freud was one of the first psychologists to comment on the idea of anxiety, and his idea was that we have these behaviors that we really would like to engage in, but we repress them, and the process of repressing these behaviors turns into anxiety. Pardon me. Learning theorists like Watson and Skinner, these sort of founders of the behaviorist movement, and then later on Albert Bandura, who you see pictured here, argued for observational learning. They suggest that we can learn anxiety through fear conditioning. So we begin to worry about some particular event pretty intensely, and then this becomes generalized into sort of an overarching sense of worry. So the idea here is that you can learn to be anxious through experience. Evolutionary psychologists talk about phobias being sort of adaptive, right? So if you don't know what snakes are poisonous, being afraid of all snakes has positive survival value, right? If you stay away from snakes, it's pretty good. There's some evidence to suggest that there is a genetic component to phobias. So genetically identical twins more likely to share phobias than non-identical twins. The heritability is pretty strong. So for things like well, we'll talk about that here on the next slide. So some of the causes of these anxiety disorders. Generalized anxiety disorder. People with generalized anxiety disorder tend to have a history of sort of unpredictable or uncontrollable life events. Lots of crazy things, for lack of a better term, happen to them that makes them hypervigilant towards threats. We see increased GABA activity. Inhibited GABA activity. GABA is a neurotransmitter, and decreased activity with GABA is associated with increased anxiety. Panic disorders tend to be genetically linked, so there's 33 to 43% heritability when it comes to panic disorders. Also neurobiological factors, so overactivation in the amygdala, the sort of fear center of the brain. Also this inhibited GABA activity, abnormally low. So GABA tends to be abnormally low in people with panic disorders. Also sort of conditioning components. This can be similar to phobias, sort of intense fear reactions. That are sort of learned through conditioning, sort of pairing some kind of object with intense fear, or through direct observation, sort of observing someone experiencing fear. PTSD, the causes for PTSD tend to be, this severe traumatic experience and an unsupportive social environment. And there is some evidence for for a biological predisposition. So some people are just more likely to suffer the negative effects of a traumatic experience than others. But the causes for PTSD is relatively unknown. For OCD, we talk about, for obsessive compulsive disorder, we can talk about this sort of two-stage conditioning process, right? So you have this severe anxiety response and a behavior that alleviates that anxiety. There are also inhibited serotonin activities associated with obsessive compulsive disorder. There's also genetic predisposition. So if a direct family member has obsessive compulsive disorder, you're 3 to 12 times more likely to develop it yourself. And I think that's it for obsessive compulsive disorder. So that's it for today. We'll come back for part 2 of disorders, and we'll discuss information and issues surrounding mood disorders, schizophrenia, as well as dissociative and identity disorders.